Hi, my name is Kath. I'm a trainee advanced clinical practitioner at a couple of emergency departments in the north of England, paramedic by trade, and I read the Emergency Medicine Journal so you can pretend you have. This month we are looking at March 2025 because I'm still a little bit behind, but I'm catching up. And in this issue we've got some stuff about patient experiences from a couple of perspectives. We've got some global health. We've got yet another use of point of care ultrasound in the ED, and some stuff about ED ACPs. So let's get into it. So the first couple are about patient experiences. So the two qualitative pieces about patient experience this month are being a patient in a crowded ED, a qualitative service evaluation. That's by Craston et al. They're in Leicester and Sheffield. And then we've got care for older adults living with dementia in the emergency department, a systematic review and meta-synthesis of care partner roles and perspectives. That's by Jelinski et al. In Alberta in Canada. So the first one is specifically about patient experience in crowded EDs. So they interviewed 7 patients and 3 accompanying partners aged between 24 and 87. And it wasn't just waiting in ED, it was like crowded EDs. So at the time of the interviews, there was greater than 100% bed occupancy and there was a 12-hour wait for a bed. Familiar picture at the moment. Some themes they pulled out were loss of autonomy, unmet expectations, vulnerability. And in terms of potential interventions, as quick takeaways, the main ones seem to be information, like let people know what the wait times are, explain processes, what are people waiting for, why is it slow, what's happening next, and then the classics of bruise and butties and telly make waiting a lot more tolerable. So useful response, I think, to ED crowding, like let's be getting this data, let's start exploring people's experiences. I think from a pre-hospital perspective, it's useful to anticipate crowded EDs. I mean, I know everyone does anyway, because you know you're going to wait ages to hand over, but I think anticipating experience of waiting in a crowded ED for patients once you've handed them over is useful as well. I think something I used to do on the road was kind of explain what was going to happen next once you arrived at hospital, because I think it's quite a privileged time when you're one-on-one with a patient and you really have the opportunity, if you can have a discussion with them, to explain what's happening next, what you think's going on. And I remember I would always do it for PPCI. If you're taking a STEMI in for PPCI, actually it's a kind of pile-on once they get there, when they get there. Just speaking in poetry all of a sudden. And I think I took a few patients and watched them get totally overwhelmed in that way before I started being like, actually, I've got 20 minutes here, there's not that much to write. Once you've made the call and you're heading over, especially if you think you might have longer journey times to like a tertiary centre, here's a really good opportunity to tell someone they're having a heart attack, which sometimes you can find yourself not doing. Certainly when I first qualified, you almost like dodge it. But if you're taking them for PPCI, you're pretty happy that they're having a heart attack. Explain they're having a heart attack. Tell them what a heart attack is, because a lot of people don't understand. Explain what PPCI is, and explain what that will look like. We're going to take you straight from your bed, this trolley, onto like an operating table. And also when we get there, there's going to be 6 people around your trolley and they're going to be cannulating you again. They're going to be giving you some meds. They're going to be like waving a consent form in your face and explaining the procedure, except like all in one like monologue that they've done 50 times before. Like actually that's a really good way, like opportunity to prepare people for that. And it lets them anticipate it a little bit. So I think that could be a really valuable thing to do pre-hospitally, and I wonder if that is something that is transferable, like looking at the potential interventions here of like improved information sharing, of actually like letting people know it's going to be busy, and also like what you're going to wait. Like we're going to put you in a cubicle and then you're going to be seeing someone who's going to come and check your observations, a nurse is going to speak to you, and then like there will be a wait for a clinician, and then this is what will happen. And then the next piece is specifically about the experience or the perspectives of care partners of patients with dementia in the emergency department, and also the perspectives of healthcare professionals on those care partners and their role in the ED. So, you know, like the spouses of dementia patients that come in, tell you all their history, look after them, keep an eye on them, often look kind of like pretty burnt out. So it's exploring their perspectives, HCP perspectives, and pulls out again some themes. So talking about the importance of primary care in preventing A&E visits in the first place, like planning for progression rather than it kind of taking everyone by surprise that this progressive disease is progressive. Also like where there's poor record keeping and sharing and no care plans made, that's when we get to these crisis points where people end up in ED. And also it means if they end up in ED without carers, then we really struggle with that without that information. So it increases kind of carer strain if we're not sharing information in other ways. And then also like crap privacy, poor communication in the ED, under triaging of patients with dementia, and poor discharge communication. So the takeaway again is communication really matters, primary care really matters. And I suppose this is interesting partly because there's so much information in the references here. So a useful bit about the experience of carers of dementia patients in the ED, but also if you're writing about dementia, if you're writing about patient experience or the experience of dementia patients, if you get into the reference section of this research, that will just write your whole reading list for you. There's loads and loads in there, so worth a read for that. Okay, then there's a couple of global health bits, if anyone is interested in these things. So there is one called Designing, Implementing and Evaluating Multidisciplinary Healthcare Training Programs in the Wartime Humanitarian Context of Ukraine by Kivlehan et al. So this is writing about a program to adapt the Ukrainian healthcare system to meet the new conflict needs over there, and also the changed demographics, like the movement of people, changes in resources and things. I'm not going to go into their particular conclusions, but if you are interested in that, then that is one to read. There's also one about strokes in Bangladesh. It's looking at delayed stroke presentations, talking about how late people present after the onset of stroke symptoms and what can be done about that. There's loads of numbers and stuff in there. So if you're interested in strokes or Bangladesh or strokes in Bangladesh, then that is one to read also. Then the third international research here is from Haiti. So the paper is called Epidemiology and Outcomes of Patients with Cardiac Arrest in the Emergency Department of a Lower Middle Income Country, that being Haiti. That's Edmond et al. So the rationale for this. So ACLS, Advanced Cardiac Life Support, which is what they refer to here, is poorly studied in low and middle income countries. We know that there's wildly varying ROSC rates in low and middle income countries. So for patients who have had CPR, so some attempt at resuscitation, ROSC rates vary between 24 and 71%. So huge variation. In terms of survival to discharge after CPR, that varies from 4.2% to 30%. So we know this is massive variation. So this was a prospective observational study of adults and paediatric patients who had in ED cardiac arrest, so cardiac arrest in the emergency department. And the primary outcome was survival to 24 hours post-arrest. So they pulled the data for 161 patients. The mean age was 45 years old, which first thought, that's really young. If you think about the arrests that we see, 45 is really, really young compared to a high-income country. The most common presenting diagnoses were pneumonia, sepsis, cardiogenic shock and stroke, which again is really different to my experience working in a high-income country. You don't see many cardiac arrests due to pneumonia. Like, they might die later if they're septic, but in the ED, there's loads we do for them, so it's rare that you would get someone like peri-arrest. So 161 patients, so 43 of the 161 patients received ACLS, so that's 27%. The rest were deemed to have poor prognosis or of irreversible cause, so resus wasn't attempted. They got a ROSC in 2 patients, and 1 survived to 24 hours, and none survived to discharge. So remember, in a high-income country, you would expect about 35% of patients who have ALS after an in-hospital arrest to make it to discharge. So really rubbish outcomes. Why? Well, limited resources you'd expect. It's a lower middle income country. So resources in terms of, yes, the arrest themselves, but also kind of that crit care support when someone's peri-arrest, say they're really septic, their BP's tanked, that kind of support. But also pre-arrest monitoring, so people often hadn't had their observations done for hours and hours before they arrested because there aren't enough like OBS machines to go around. There's only like a handful of you know, like cardiac monitoring or SATS probes. So you're sharing them around the department. You can't have people just hooked up to continuous monitoring. So therefore, you're not going to recognise that deterioration. Also, they discussed the increased burden of infection, sepsis in hospital cardiac arrests in low and middle income country, which fits with my first thoughts of it. We do see a lot of sepsis, but I don't think see that many cardiac arrests due to sepsis. Whereas clearly that was more of a factor here. So some more context, 89.5% had MUs, so like news equivalent of 5 or more before arrest, although that was often hours before because they weren't having like contemporaneous, is that what you mean? They weren't having obs done like super regularly. And they said there was 126 patients, it was recorded whether the clinical team anticipated the arrest or not, and they did in 87 of those. A big figure actually is the median time from check-in to arrest was 23.6 hours, so they're nearly a whole day after arriving, which I guess when I think of ED arrests, it's usually like someone turns up having a massive STEMI and then arrests in triage. Like the idea that someone would sit there for a day and then arrest is less common. Firstly, sitting there for a day, it does happen with all the bed blocking and stuff that we see, but like it's not that common. For that to be the median time in the department before arrest is a day is pretty wild and very different to a high income country. Also, in terms of the initial arrest rhythms, when they were analysed, which was not most of them, about 60%. Initial rhythm assessed in 58.1%. So of the people that arrested, 6 out of 10 had their arrest rhythms looked at, and they were mostly PEA and asystole, which I guess fits with if they're septic arrests or arrest secondary to sepsis and like terrible hypotension, you're going to get that PEA rather than VT-VF. But that differs from high income countries where we're more likely to have shockable rhythms. So what are our takeaways here? I mean, firstly, it's just useful getting some perspective, isn't it? I've worked abroad, but not in an ED, and it's useful understanding the difference in how cardiac arrest, or what type of cardiac arrest present, what EDs look like over there. I think the idea of, we have some resource scarcity, but nothing like a low middle income country. So good reality check, I guess. And the takeaways are arrest prevention actually in a department with more resources. Most of these patients probably wouldn't have arrested. They would have been recognised quicker if they were on monitoring. They could have been managed better if there was more resources available. So that crit care, kind of like vasopressors for a tanking BP or like non-invasive ventilation, they could all stop the arrest happening. Like once someone's arrested, actually, survival rates are rubbish. Like whichever, even in a high income country, like you're having a pretty bad time if you've arrested, aren't you? But if you can recognise it and prevent it, then that's what's actually saving lives. And the other thing is, it's not generalisable outside ED, so it's not about in-hospital cardiac arrest, it's about in ED specifically arrests, and it's also not about pre-hospital arrests. That's a whole other paper that hopefully someone will write at some point. No idea what the pre-hospital system is like in Haiti, actually. I'd be interested to find out. The next one is quite sexy. Endotracheal tube as chest tube, a backup alternative in resource-limited settings, by Schuller et al. From Amsterdam. So this is talking about, chest tube you stick in to let out air or blood or whatever as part of a chest drain. It's its own thing, like a little tube, and then you put it in and you make a hole, you stick your finger in, and then you stitch it in place and then everything comes out. That's fine. This is about whether you can use an ET tube, like an endotracheal tube instead, because that's also a tube. They are interested in looking at this because it would be helpful in resource limited environments. They talk about mountain rescue, where if you could just carry an ET tube instead of extra kit that you're carried up Everest or wherever, then that's good. Or a Majax, where it's easier to find a stash of ET tubes than it is chest drain kits. Or personally, maybe some kind of apocalypse scenario. I don't know. Just always thinking about the apocalypse. So could this be useful for our post-apocalyptic survival planning? Well, it sounds like yes. Actually, they're pretty useful. So ET tubes are slightly wider diameter, they're slightly more rigid, so that actually works well as a chest tube. It doesn't kink as much. It's also at the like opening of it. I'm gonna be real, it's quite a while since I saw an AT tube since they took it off. Anyway, it opens up and then you've got that like little eye, little hole, Murphy's eye. So there's actually two, there's a big opening and then there's like an extra little one. They were saying actually that's quite nice because the big or either opening can kind of get blocked by whatever gunk is in there, but it means the other one's open. So that actually can work nicer than a chest tube. It's less prone to kinking. And then also you can fix it. So if you, a proper chest tube, you have to stitch it with some sutures, which not ideal in a chaotic post-apocalyptic situation because that's a pretty grim needle stick injury. So safer in an ET tube, you just inflate the balloon cuff, which I kind of like. There's also a wild picture, which I need to show you, of a chest x-ray. This patient has ET tubes in as chest drains on both sides and also an ET tube in his trachea for ventilation. So I think 3 ET tubes in your body at once is probably quite a bad day, isn't it? Anyway, now we know that can be done. So just save that information for when the zombies come is all I'm saying because it's kind of useful. And the next little bit, I'm going to not talk about these loads because it's maybe only interesting to ED ACPs, of which I am one. But it might be worth thinking about if you are a paramedic that is thinking of trying to become an ACP. Or you have an essay to write about the changing role of ACPs in your environment, because that's exactly the kind of thing they would like you to write about in year 1 of your masters. So first up, there's an opinion piece from Dr. Ruth Brown in Imperial College, How Can We Improve on ACP Training? And that is commenting on a piece called A Qualitative Study Exploring the Experience of ACP Training in Emergency Care in the Southwest of England, UK by Ablad et al. So this is looking at a Health Education England, RIP, pilot in the Southwest. It's qualitative. It's very qualitative issue actually this month. So it's qualitative with semi-structured interviews looking at the experiences of trainee ACPs and consultant leads who took part in this pilot. One thing worth mentioning is it happened during COVID, so that threw a bit of a spanner in the works, but they did manage to pull out some themes. I'm not going to read it all for you, but there were some quotes that resonated with me. One of them was, one trainee emergency care ACP said they felt like they had been drop-kicked into the fire, with another stating it's probably the most extreme kind of process I've ever been a part of. So that does sound a lot like year 1. There's also someone saying, I still refer to myself as a paramedic. I still see myself in that role, but with the ACP attachment to it. Someone else said, I just know that I'm not a doctor. So these all make me feel seen. And also, another paramedic background ACP said, for 10 years, no one ever stepped foot in the ambulance and saw me assess a patient. Whereas in medicine, obviously, it's a constant cycle of being assessed by your peers and getting feedback. You're in this constant feedback loop, which is completely new to us, but it makes you feel really supported compared to where we've all come from previously, which really resonates with me as well. Like, you're so scrutinised once you work in ED compared to pre-hospitally that it's really terrifying at first, and because you just feel like everyone's going to notice that you're terrible. But then I think the flip side of that is actually like you get positive feedback, which fairly new to me, having come from the ambulance service where they kind of just leave you to it unless you kill someone. But also you get like real-time feedback of like where you can be better and like what you did well, and it gives you so much more like fodder for pushing yourself. It is really different culturally from that perspective, and it's one of the things I like the most about the job actually. So this paper is worth a read if you are thinking about trying to get on ACP training or have to write an essay because you're already on ACP training. But also if you're a paramedic that like is kind of chewing over what to do next. This does give it gives a picture of ED ACP training that I recognise for better or for worse. So worth a read from that perspective. There's also a letter, the ED ACPs in England and English Workforce Census. So basically there's no clear data on ED ACPs because ACPs isn't a registered protected title. Like we've all got our, HCPC or NMC registrations as nurses, paramedics or whatever, but there's no ACP registration, which is an issue. And also because Royal College of Emergency Medicine membership is voluntary, there's no kind of complete data set. So they did a workforce census. They got 326 usable responses where they asked people. I participated in that actually. I remember getting kind of spammed with messages, so I was like, fine. So people had to describe the ACP makeup of their entire team. So they got 326 responses covering like a greater number of stuff than that. So they identified 687 nurses, nurse background ED-ACPs, 123 paramedics, 17 physios, 5 ODPs, 3 pharmacists and 1 radiographer. So an interesting one. I think sometimes it feels a bit isolating being a paramedic background ACPs. I think less so in the ED than anywhere else, but like on my master's course there's only 2 paramedics out of 50 people. In my prescribing there was only 2 of us out of 50 people. But now I see that we are actually the second most well represented profession in ED as ACPs. And there is 1 radiographer, so I don't know whether they feel very lonely and sad or like a superhero. Either way, that's full on, isn't it? So yeah, 123 paramedics at least. Point of care ultrasound. We learned last time that you can look for organic matter in someone's leg with POCUS if you really want, and this time it turns out you can detect paediatric skull fractures using POCUS. So that's another one. I might start keeping a list back of things you can do with ultrasound if you wish. So yeah, we can look for skull fractures in babies, I guess, because we're trying to limit the radiation of putting them through CT. Fine. And then the last one that I think is really relevant, actually, finally, is early restrictive versus liberal oxygen for trauma patients, the TRAUMOX2 randomised clinical trial. So this is from a different journal, but they've just given us a little snapshot of it. So this was an RCT that ran in Denmark, Netherlands and Switzerland. It compared restrictive oxygen in major trauma, which is to say you only give oxygen to keep someone at 94% or above in saturations, or liberal oxygen where you just wham everyone on high flow, 12 to 15 litre a minute oxygen. So it was an RCT, compared 1 versus 1, and they found there was no difference in outcome really. So their conclusion is restrictive oxygen therapy is probably not different from liberal oxygen therapy in major trauma patients. I actually not sure what the local pre-hospital guidance is, because I remember getting trained of like, if it's major trauma, high flow oxygen, don't care. I mean, also when I started, if someone was having STEMI, high flow oxygen, don't care what their saturations are, and that got knocked back, I think, earlier than, I'm not totally sure where we stand now, and I'd be interested if anyone could tell me. Are we just fundamentally putting all major trauma patients on loads of oxygen, or are we being a bit more thoughtful? I'm trying to think what I've seen come into ED recently, and I feel like people are coming in without oxygen, but I'm not sure. Anyway, if you are getting told to put oxygen on someone, because that's just what we do. And there's my neighbour walking past, watching me record myself, brilliant. Yeah, if someone is telling you to put oxygen on just because that's what we do with major trauma, you can now wave this paper at them if that's your sort of thing. So that's all for this month. Thank you so much for watching. I do appreciate it. Do let me know what you think if I've said anything stupid. A couple of months ago, thought I should promote this a bit more, because I do like, you know, I really want to talk about research, and I really want paramedics to talk about research. So let's just promote this a bit more, even though it's a bit embarrassing. And then like 600 people watched the video, and I felt so self-conscious that I just felt like a bit sick for about 3 days, and then I didn't record another one for about 2 months. So for both of you that are watching, I really appreciate your attention, and I'll see you next month. Bye.